Sinha is going to highlight the dual antiplatelet in coronary artery disease with a special reference in acute coronary syndrome. Over to Dr. A.K. Sinha.
Good morning, ladies and gentlemen. I really feel honored in giving this lecture, and I'm honored to be at this conference. I really thank Dr. Professor A.N. Rai for allowing me to speak on this subject, and I'm again honored when I see my chairman, the giant personality, Professor Rajasthan, who is a walking encyclopedia. You have seen whatever subject you speak, he has got everything, and the other co-chairman. It's a fine morning in this place, Mount Abu, and this is my first visit in Mount Abu. Now I'm going to speak on this subject, which is very clinical. I have taken some facts from epidemiology and some facts from the pharmacology to make the subject interesting and very clinical. I am not going to talk something very research type of the paper, so I will be very simple to the point. Now, we all know why we are interested in antiplatelet drugs, because it is antithrombotic, we all know. The coronary artery disease is #1 cause of death in USA, although the mortality in developed country is decreasing, but still it remains so accountable for approximately 1/3 of all deaths over the age of 35 years. Additionally, about 50% of all male and 33% of all female beyond middle age will have some form of the coronary artery disease. So it is really hell of a figure which compels us to work on this subject. Now, to make the anti-thrombotic strategy in coronary artery disease, I am talking of the atherosclerotic coronary artery disease. Antiplatelet is part of our anti-thrombotic strategy. It's a very old friend of ours, clinician, and it is very effective in acute coronary syndrome. And you all know, just a revision, that acute coronary syndrome involves plate fracture, fissures, erosion with exposure to subendothelium, leading to recruitment and activation of the platelet. And there is a generation of the thrombin, leading to formation of the fibrin-rich thrombus. When there is non-occlusive thrombus, it leads to unstable angina and STEMI. And when there is total occlusion, it is STEMI. Now, the platelet cascade is not very new to any of us. We all are aware of it. Just to make the talk complete, we know the adhesion, activation, recruitment, and aggregation. This is one part of the thrombotic phenomena. The other part is coagulation factor. Ultimately, both leads to generation of the thrombin, which forms fibrin and fibrin from fibrinogen. So that to make the system complete, to make the phenomena complete, so I am repeating this slide. Now, what are the antiplatelet drugs which we are going to talk about, or which we are going to use about? We have got 4 major classes of the antiplatelet drugs: COX-1 inhibitor, ADP-P2Y12 receptor antagonist. The most important is clopidogrel, prasugrel, and ticagrelor or andrelor. Then we have got parenteral drugs, that is glycoprotein 2B, 3A inhibitors, tirofiban, eptifibatide, and epsimal, and PAR1 receptor antagonist, vorapaxone. The aspirin, I added one slide. It is very well known to all of you that it irreversibly inhibits COX-1 and COX-2, and in smaller dose, COX-1 is inhibited, and there is a less thromboxane A2 generation, and there is a mode of prostacyclin which has got its different roles, and favorable roles by prostacyclin is it decreases platelet aggregation, it improves the vasodilation, inhibits smooth muscle cell, and is anti-atherogenic. Few words about it which many of us know, but many of us are not very clear about. What does soluble aspirin and enteric coated aspirin make difference? The peak plasma level we are interested. With the soluble aspirin, peak plasma level of the platelet is reached in 30 to 40 minutes, and with the enteric coated, it is reached in 3 to 4 hours. So how fast we reach, how fast we get the therapeutic level of the antiplatelet, that is important. What does low dose aspirin means? It means the dose less than 100 milligram per day. What does DAPT stands? Is a dual antiplatelet strategy when we use low dose drug and add to it P2Y212 inhibitors like clopidogrel, prasugrel, ticagrelor. Every day we are writing it, but sometimes we are not using it, why we use it, how we should use it. Now the few pharmacological background about these drugs, clopidogrel, prasugrel, ticagrelor, all are oral, to be used orally. Frequency in the clopidogrel and prasugrel is OD dose, and in ticagrelor it is BID. It is important to know that ticagrelor has no prodrug. It is active by itself as it goes in the blood, but clopidogrel has got is a prodrug, and it needs to be metabolized before being active, and likewise prasugrel. The onset of action is very important to know. The onset of action in clopidogrel is 2 to 8 hours, and in ticagrelor it is 30 minutes to 4 hours. The enzyme inhibition by cytochrome P2C19 is also important to know. What drugs can induce or decrease the metabolic aspect. The dose reduction, dose adjustment is not needed in ticagrelor, but it is needed in prasugrel. It is also not needed in clopidogrel. Clopidogrel is only 15% is metabolized to active molecule, so loading dose needs to be given in a high portion. It should be either 300 milligram stat or 600 milligram depending on the clinical situation, and the maintenance dose is 75. This is the why we are giving that much of loading dose, because the active form is only to 15%. Prasugrel is again hepatic metabolism to active drug, so it also needs a very high loading dose, 60 milligram. Contraindication, all the bleeding conditions with a history of stroke, hypersensitive drug, and age, elderly age, like 75 years and above. But in very high risky situation, it can be used, for example, in diabetes and prior MI. In elderly, we reduce to half, 5 milligram only. Ticagrelor is a test of time, is a very good drug, and it's a very fast, direct acting antiplatelet. Metabolic transformation is required only in 30 to 40% of drug is metabolized. Reversible inhibition, so faster offset time. If we stop the drug, the effect will pass off quickly. The primary effect is P2Y12 inhibition, but there is a secondary effect as well. There is an increased generation of adenosine with the ticagrelor. There are two factors, two situations arises with this adenosine level. First, increased adenosine level, it decreases platelet aggregation, a vasodilation of arteries are increased and inflammatory response is decreased. These three actions are favorable effect, but there is unfavorable situation also. It stimulates vagus C fibers and it creates dyspnea, feeling of dyspnea. There have been reported ventricular pauses, creatinine level is increased, uric acid is also increased. Ticagrelor, the hepatic metabolism, 30 to 40%, as I said, by CYP3A enzyme to active metabolize. The rest are active drug by itself. If you use few medicine, it will have some effect. If you inhibit this enzyme by ketoconazole or itraconazole or clarithromycin, this 30 to 40% of the drug will not be activated. So there will be less antiplatelet activity. But if you increase or induce, there will be more activity by the many drugs. Ticagrelor plateau trial is very important, and all-cause death has been 20% lower in the ticagrelor arm. Primary composite endpoint has been 9.8% in comparison to 11.7% with ticagrelor, with the clopidogrel. I'm sorry. Parenteral antiplatelet drugs, you can always refer the doses. It's complicated. When you use, I always refer the doses. What is important point for the clinician is to know when to use the parenteral antiplatelets. We should use it when there is an acute coronary syndrome undergoing PCI. But we have got a treatment alternative oral. Ticagrelor is almost as effective. In diabetics with coronary artery disease undergoing PCI is a special group. These have worse outcome after PCI, and GP inhibitors in large meta-analysis show 22% reduction in mortality in next 30 days. So it is important to know when to use parenteral antiplatelet drugs. Now let us talk about the clinical scenario. When a patient comes of anastemia, what drug we should give? It should be very clear in mind to the clinician so that we don't waste time or we don't commit mistake for the benefit of the patient. The loading dose has to be given of the aspirin, 325 milligram, soluble aspirin, and then add DAPT strategy, add P2Y12 inhibitors. The number one choice now is ticagrelor, loading dose 180 milligram and then followed by 90 milligram BID. This is preferred over clopidogrel irrespective of strategy, whether we use invasive or non-invasive strategy. The second choice is clopidogrel, 300 to 600 milligram loading dose followed by 75 milligram OD. And the third is prasugrel, particularly for those patients who are going for PCI. Parenteral antiplatelet drugs we use in anesthesia only in high-risk patients or when the patient is going for early invasive strategy. Daptaptibutide and tirofiban are preferred due to shorter offset times. Other aspects of anesthesia management is not in the scope of my talk. Anesthesia, early invasive indication we should know, because we should do a favor after the basic treatment to the patient, fully explaining the pros and cons of the invasive versus non-invasive treatment. If the patient has got refractory angina or the patient has got resting ischemia despite medical therapy, signs of heart failure, new or worsening mitral regurgitation, hemodynamic instability, recurrent angina, sustained VTAC, VFib, dynamic ECG changes, rising troponin level, diabetes mellitus, chronic kidney disease, GFR less than 60 ml. left ventricular ejection fraction less than 40%, prior CABG, PCI less than 6 months, TIMI score 2 or more. We should tell the patient that, look here, your patient needs invasive treatment. Initial conservative treatment is utilized when there is a lack of those factors which I have just mentioned, patient is troponin negative, or the patient or clinician prefer in absence of high risk factor, their preference has to be given importance. Clinical scenario number 2 is STEMI. If the patient with STEMI comes, we have two situations, whether the patient is PCI capable hospital or PCI non-capable hospital. In PCI non-capable hospital, no emergency angiography to be done. As per ACC guideline, give immediately aspirin, give ticagrelor, clopidogrel, if not available. But mind you, one situation, if the patient is immediately going for thrombolytic treatment, they prefer that instead of ticagrelor, clopidogrel should be given. And if the patient is less than 75 years, loading dose 300 milligram and OD, maintenance dose 75. But if the patient is aged more than 75 years, 75 milligram in both the situations. Alternative drug, of course, is ticagrelor. In intravenous antiplatelet drug, only in the situation when there is no reflow or the bailout situation. If the primary PCI is available, okay, go ahead, give the aspirin, give the ticagrelor and send the patient to PCI. Clinical scenario number 3 is stable coronary artery disease. In this situation, we just give aspirin, and when the aspirin is contraindicated due to so many reasons, give clopidogrel instead of aspirin. DAPT is given in post-PCI patient, and ticagrelor and prasugrel are not used in stable coronary artery disease. Summary: DAPT is accepted and proved in acute coronary syndrome, but the contraindication of the dual antiplatelet therapy should be understood and taken care of. If the patient has got very short life expectancy and poor expected DAPT adherence, then we should refrain from giving it. Malignancy, end-stage renal disease, smoker, advanced age, poor mental status, advanced liver disease, active peptic ulcer disease, anemia, thrombocytopenia, bleeding diathesis, uncontrolled hypertension, prior history of bleeding or hemorrhagic stroke, and if the patient of atrial fibrillation already on anticoagulant therapy. That is indicated in all the situations which when the ischemic risk outweighs the bleeding risk, like recurrent ischemia, stent-related complication, acute coronary syndrome, male, diabetic, liver dysfunction but mild or moderate, chronic kidney disease, peripheral vascular disease, prior ischemic stroke, myocardial infarction, clopidogrel non-responsiveness. Special categories are elderly, women, women and diabetes. The last slide is ticagrelor is effective in full spectrum of acute coronary syndrome. It is preferred over clopidogrel irrespective of strategy in STEMI. But in STEMI, it is also used, but only in one circumstance, and if you are immediately giving thrombolytic treatment, then clopidogrel becomes the first choice. Now the new slogan which was given in ACC conference in 2018 was that you should tell the patient to chew in the mouth P2Y12 inhibitors, like either you use clopidogrel or ticagrelor or any drug. Chew in the mouth or crush the tablet and then give to get the quick effective blood level. Now they have demonstrated auto-injector also. for these drugs and subcutaneous injection so that the blood level is immediately reached without wasting time. And the main thrust is to reach the patient's blood, reach the active level, effective level, therapeutic level as early as possible. Thank you very much for your patience.
Thank you, Dr. Sinha, for enlightening on the dual antiplatelet. Let me pose one query. What's your advice of the dose relation of aspirin with weight? For example, below 70 years, low dose aspirin. Above 70 years, high dose aspirin. There is a recent study. What's your comment on that?
I always in ACS I give the 325 milligram without any question.
In fact, what they claim, a recent article,
But
below 70 years, only low dose. Above 70, low dose may not be effective, only high dose. Whereas high dose aspirin is not effective below 70 years. That is their observation.
high dose I use only for acute coronary syndrome, and otherwise when I use DAPT technology, DAPT strategy, I use low dose plus I add.
Irrespective of the weight.
Yes, this is my practice.
And what's your advice of combination of rivaroxaban NOAC with aspirin? There is also a study. Though rivaroxaban was previously claimed to be causing ICH and all, but now there is a approval of combining rivaroxaban plus aspirin to prevent the vascular events. What's your advice? Comment.
Depend on the clinical situation, clinical scenario, I will decide on each individual case. I will not make a rule of thumb for this situation.
Thank you. Any more questions?
No, thank you.
Otherwise, we will close down and we will invite the next speaker. Thank you very much.